In this presentation, we will review the basics of valvular heart disease. The major sections of the video are hyperlinked in the description below. Let's get started. These are the objectives of this presentation. Please use this as your knowledge check mechanism so that by the end of this presentation, you are able to do all of these. Let's get an overview of the valves of the heart and valvular heart disease. As you have reviewed in cardiac anatomy before, there are four valves in the heart: the tricuspid, mitral, aortic, and the pulmonic valves. What are valves in respect to cardiac and vascular system? So valves are structures within the vasculature as well as in the heart that allow unidirectional flow of blood. It is similar to mechanical valves we encounter in non-biologic systems. Under certain circumstances, these valves may be either anomalous or defective because of disease. Valve disorders or diseases caused by the presence of congenital anomalies and deformities, or they may be damaged from process of infections such as rheumatic fever or disorders such as thrombosis. Valves have continuous flow of blood across them, hence they are always under stress. Valves that see higher blood flow result in more damage, and therefore certain valves like the mitral and the aortic undergo more damage than the ones that have lower pressure of blood flow across them. We come across three types of valvular disease generally: stenosis, insufficiency or regurgitation, and prolapse. So valvular stenosis, valvular insufficiency, valvular prolapse are the three broad categories of valvular disease. In valvular stenosis, as you can see in the picture, a normal valve will open wide when it is transmitting blood. However, stenosis indicates a narrowed valvular opening where it is unable to open with the pressure of blood behind it. This causes back pressure and eventually backflow, which is regurgitation. The heart muscle has to pump harder and harder in the chamber behind the stenosed valve, which eventually leads to heart failure. Valvular stenosis usually occurs from failure or damage to the leaflets of the valve. Valvular insufficiency refers to regurgitating valves, which occur when the valvular leaflets become loose and unable to close during the closure phase of that valve. When such a regurgitation starts occurring, the initial response is retrograde flow into the chamber behind that causes dilatation of that chamber. Eventually, this dilatation will convert to remodeling of the chamber and result in hypertrophy and eventually heart failure. And then valvular prolapse occurs when there is enlarged or defective valve leaflets that bulge back into the back chamber, as shown in the picture. The commonly affected valvular prolapse is seen in the mitral valve because the pressures of the left ventricle are the highest within the heart, with the greatest amount of gradient working on the mitral valve during the ejection phase of the left ventricle. So the sequelae of valve disorders is essentially that the back chambers usually see a significant increase in cardiac workload, and uh, the high pressure zones are the worst affected, which means the left side sees worse affection than the right. Typically, this leads to cardiac pump failure over time, and the symptoms would be commensurate with the valves involved and the related anatomy, and can be directly correlated with heart failure. So let's look at the investigations that are done in valvular heart disease. There are many different options to evaluate valvular heart disease. The management decision is not based on a single parameter and is usually a combination of a clinical assessment by an experienced clinician and a significant disparity between a clinician's assessment and imaging outcomes should be a reason for further investigations. The most common investigation in valvular heart disease is transthoracic echocardiography, or TEE as it is commonly called. In transthoracic echocardiography, a transponder is introduced into the esophagus down to the chest area where it can look or get a view of the heart from very close up by avoiding the thoracic wall. Additional investigations that are done in valvular heart disease include cardiac magnetic resonance imaging, cardiac CT, coronary angiograms, and investigations for comorbidities such as COPD. And if the stress on the heart is rising, then it also shows up on cardiospecific biomarkers such as troponin I and troponin T. This is an image showing a transesophageal echocardiogram where the arrow is pointing towards a jet of moderate regurgitation in the mitral valve into the left atrium from the left ventricle during the ventricular systole. In this transesophageal echocardiogram, the anterior mitral valve leaflet is showing as prolapsing back into the atrium. The leaflet fails uh, to stay in place and is displaced back into the left atrium from the left ventricle. And again, this happens during a ventricular systole. Let's now look at the medical management of valvular disorders. The management of valvular disorders depends on asking several important questions. What are the symptoms, if any? What and how severe is the lesion in the valve? And how is the relevant ventricle coping? Cardiac imaging is crucial for accurate determination of the nature and severity of the lesion, ventricular size, and function, and thus an indispensable component in the management of valvular heart disease. The drugs used in valvular heart disease aim to reduce the circulating blood volume, and this is done by the use of diuretics. Reducing the afterload, especially in aortic regurgitation, allows blood to flow into the aorta well and not fall back into the ventricle through a regurgitating aortic valve. Anticoagulants like warfarin provide heart rate control in mitral valve disease and in atrial stenosis. Drugs like negative inotropes must be avoided generally. So, for example, any kind of beta blockers or ACE inhibitors or ARBs are not usually drugs that are used in patients with valvular heart disease. Drugs can only go so far in disorder management when the main problem is structural failure of the valve, and eventually there is buildup in the chambers behind the faulty valve, which will start having excessive workloads on the heart due to blood pooling from the structural disorder. This lead to, these, this leads on to the onset of symptoms as discussed in the next slide. Additionally, the left ventricle begins to fail. The degree of structural valvular disease determines both the symptoms as the degree of heart failure. Together, these are the criteria for considering surgical intervention. The clinical manifestations in progressive valvular disease is quite predictable. Given that these patients portend to heart failure, they demonstrate all the symptoms relative to heart failure. The symptoms resemble the site dysfunction where the valve is located, uh, which is diseased. In general, everyone is short of breath and intolerant of exercise, which is progressive in nature as per the grade of valvular dysfunction. These patients are not candidates for cardiac rehab, though other physical therapy measures for conditions such as orthopedics may be cautiously undertaken where significant exercise increase is not utilized as an intervention. Very succinctly, increasing exercise in patients with established pre-surgical heart valve disorder will render the patient embarrassed in a decompensated heart failure and thereby further decline in the functional capabilities at the very least. There are two major types of valvular heart surgeries: the valvuloplasties and the valvular replacements. Valvuloplasties refer to repair rather than replacement of a cardiac valve. The type of valvuloplasty depends on the cause and types of valve dysfunction. Repair may be made to the commissures between the leaflets in a procedure known as commissurotomy, and it is done to the annulus of the valve by annuloplasties, and to the leaflets or the cordes by chordoplasty. So commissurotomies are the most common valvuloplasty procedures. Each valve has leaflets, and the area between the leaflets, the site where it meets, is known as the commissure. The leaflets may stick to one another and thereby close the commissure and lead to stenosis. Less commonly, the leaflets may fuse in such a way that in addition to stenosis, the leaflets are also prevented from closing completely. So this results in the blood unable to flow forward and eventually flows backwards. A commissurotomy is the procedure to separate the fused leaflets of the valve. Now, commissurotomies can be closed in which it does not require cardiopulmonary bypass. We will refer to cardiopulmonary bypass in the surgery lecture. However, it is a process in which the heart and lungs are supported when the surgery is ongoing. The valve is not directly visualized in a closed commissurotomy. The patient receives usually a general anesthetic and a mid-sternal incision via which the heart is accessed. However, the physician does not view uh, the valve. They usually introduce a finger inside the heart using visual inspection and uh, and then perform the commissurotomy. This has been performed on mitral, aortic, tricuspid, and the pulmonary valves. Now, balloon valvuloplasty is another type of closed commissurotomy, which is beneficial for valves such as the mitral valve in younger patients and for the aortic valve stenosis in elderly patients. It is also done on patients with complex medical conditions that place them at high risk for the complications of more extensive surgical procedures. Most commonly, it is used for mitral and aortic valve stenosis. In this procedure, a balloon is introduced through an artery into the requisite valve and inflated within the position of the valve, which separates the valvular leaflets. Patients typically remain in the hospital for 24 to 48 hours after this procedure. Now, annuloplasty refers to the repair of the valve ring, which is the junction of the valve leaflets and the muscular heart wall. General anesthesia and cardiopulmonary bypass is required for all types of annuloplasties. The procedure narrows the diameter of the valve orifice and is useful for treatment of a regurgitating valve. Another type of valve surgery is leaflet repair. In this, the damage to the cardiac valve leaflets may be reversed and thus providing additional time before a future replacement surgery that might be needed. Finally, there are chordoplasties, which is repair of the chordae tendineae. The mitral valve is often involved with chordoplasty because it has the chordae tendineae. However, there are some chordae tendineae in the tricuspid valve, but those surgeries are rarely needed. Eventually, repair procedures can only go so far. If the valve is so damaged that a repair is either not feasible or futile, then there is the option of surgical replacement of the valves. This is a viable option in many patients, and despite usual risks of cardiac surgery, they can um, give pretty encouraging results. There are two types of replacement valves. The first, man-made valves, were biologic in origin, and that is why they are called, or they are tissue valves. They are also available made from metals and are mechanical in nature, so they are mechanical valves. Both valve types have uniquely different sets of strength and weaknesses. So these are examples of tissue valves. They are also called biologic or bioprosthetic valves. They are now made from porcine or bovine sources, so either from pigs or cows. Apart from medical, there are societal issues with biologic valves. Some demographics may not want bovine valves, and others may not want porcine sourced valves when they are aware of the source. Otherwise, functionally, they are similar and have similar strengths and weaknesses. Mechanical valves come in three types of mechanisms: ball and cage, a tilting disc, and a bileaflet type. Historically, mechanical valves have been known for their propensity to damage red blood cells simply by their functional mechanisms. A clinician should periodically, and in case of a hospital setting, definitely review hemoglobin values in a patient with mechanical heart valves, especially during future post-implantation visits. So, which valve is used in which condition? The decision is based on individual discussion at any age. However, ages 60 to 65 is a broad guideline. At ages less than 60, a mechanical valve is often a good option for those who want to avoid surgery when they are older. A mechanical valve is more durable but needs lifelong anticoagulation to prevent blood clots around the metal frame of the valve. This, of course, opens up the risk of possible bleeding, and these patients need to be carefully monitored over the lifetime of the patient. When older than 65, the decision is often to use biologic or bioprosthetic valves. Typically, these valves last 10 to 15 years and the patient may need another replacement at some point. The upside is that they do not have the higher risks of blood clots or fragmentation of the red blood cells. Anticoagulation is often not needed. These are also preferred valves for those who have kidney disease or are pregnant, which is usually younger females, usually from a case of rheumatic fever in childhood, and those who cannot take anticoagulants or have a job or recreational sport or hobby which increases risk of bleeding or injury. More recently, there is an added benefit of the promise of valve in valve or quote unquote bailout valves, which is a new type of valve that can be implanted within an existing older biologic valve when new surgery is no longer a best case option. This surgery option is called TAVR, and we will discuss it in one of the ensuing slides. TAVR stands for transaortic valve implantation or transaortic valve replacement. It is a self-explanatory procedure from the video presented through the link on your slide deck. Very briefly, it is a procedure specifically for the aortic valve when it malfunctions and the patient is no longer a safe candidate for open heart valve replacement. It features a retrograde access into the aortic valve via a catheter and deploying a mechanical valve inside the diseased valve without removing it, sort of like a valve in valve procedure. Watch the video for a quick rundown of how this surgery works. The post-procedural recovery is quick and in line with outcomes discussed in the following section. Let's look at the functional outcome perspectives in patients with valvular disease. Patients with valvular disorders will progress to heart failure. Initially, even with moderate valve disease, there may be no symptoms, in which case regular activity can be pursued as per tolerance. This is true of anyone with fully compensated heart failure in diagnosed patients. There will be early fatigue with progression of the disease. In fact, fatigue with shortness of breath may be the earliest sign of the disorder per se, even prior to diagnosis, which may bring the patient to the healthcare setting. Patients on medical management will demonstrate periodic decompensation of heart failure with all the associated signs and symptoms. At this time, pursuing any added activity will further embarrass the functional capacity of the patient, similar to what you have discussed in decompensated heart failure. Patients with severe mitral stenosis cannot tolerate any activity. These patients will need surgical intervention if this is a safe procedure to be performed. If surgery is unsafe, these patients are not a candidate for physical rehabilitation. Patients with severe aortic stenosis may be able to continue some activity if they remain asymptomatic. So, the big takeaway here is that functional activity decisions are based on patient's disease and symptom severity. Advancing disease is not commensurate with cardiac rehabilitation unless surgical options are available. A patient will be the best feedback mechanism to inform the clinician on their tolerance limits. If signs and symptoms of heart failure are overtly evident, the patient needs to be referred to an appropriate specialist. A therapist can begin their referral by sending the patient to the primary care physician. Postoperatively, valve repair or replacement patients are unique in that their exercise capacity will see immediate improvements from their baseline. That is why it is almost immaterial if you do not have a pre surgical baseline. However, it never hurts to know the pre surgical baseline to understand how poor their functional capabilities were. The remarkable improvement post surgically is because there is immediate improvement of blood flow once the defective valve is fixed or replaced, and this blood flow accounts for adequate oxygenation from improved blood supply. Yes, the patient will still have pain and surgical recovery pathway that can be expected for the exact type of surgery and the surgical access. But the improvement in functional capacity is truly remarkable. A patient previously barely able to sit or stand at rest can get up and walk functional distances, especially in those who are younger and relatively in fair to good physical state, except for the valvular disease. Yes, we still do provide supervision and support in the immediate postoperative phase until the patient is assuredly independent. A cardiac rehab program as outpatient can be initiated. The discharge goals are quickly met and patient usually goes home after surgery soon after if there are no other complications. For patients undergoing open chest repair or replacement, there are post-surgical thoracic and shoulder rehabilitation or precautions that are specific for the approach and is discussed in the general surgical approaches lecture. For TAVR patients, they're typically of advanced age and lower baseline functional capacities. But even in them, we do see functional improvements after the placement of the transaortic valve. They also can be discharged home unless there are functional impairments that do need rehabilitation in an institutional setting, such as subacute rehab. In most cases, the post TAVR rehab program can be home based. This concludes the lecture on pathophysiology and medical management of valvular heart disease. You also heard the expected outcomes of treatment and the rehab options in these patients. Please do provide suggestions or comments below on this presentation. And please do not forget to like and subscribe. I appreciate all the feedback. Thank you.